And first question
I forgot to give you this.
I would ask is, where's my other microphone? Is that better? Okay. And then the second, even higher? Wow. Now it feels like I'm on the radio. Okay. Actually, the first question I would ask my students is the following. Do people have a legal right to health care in the United States? Are people born with a legal right to health care? And the answer to that question is no. People are not born with a legal right to health care in the United States. And we have some laws like EMTALA, which is the Emergency Medical Treatment and Active Labor Act. And that law basically states that if you're about to die or have a baby, you cannot be turned away from an emergency room. So there's that degree of a safety net. But EMTALA alone is not going to manage cancer. It's not going to manage diabetes or any other chronic disease. And we don't have a right to health care, and that's true for everyone in this country except American Indians. We are the only population born with a legal right to health care. And that's because of treaties and other legal bases. With our treaties, we exchanged land and natural resources for several social services, including housing, education, and healthcare. So that's why there's an Indian Health Service. That's why there's a Bureau of Indian Affairs. Those are the federal agencies responsible for carrying out the federal government's trust responsibility to us as American Indians to provide those services. I live and work in South Dakota, and the degree of lack of understanding of these issues is just remarkable. I've heard state legislators say, well, why isn't there an Irish health service or a Scandinavian health service? It's like, because they don't have treaties. They're not governments within this nation. And it's remarkable how little understanding there is. And in truth, many health policy leaders don't even recognize the fact that we have a legal right to health care. And the way I look at it is that the Indian Health Service is the largest prepaid health plan in history. If you think about what we gave up as tribes, the land and that natural resources that have made this country so wealthy and powerful are American Indian resources. And we did not lose those resources in a war, we exchanged them for these services. So if they want to get rid of Indian Health Service, that's fine, just give us our land back. So in this country, we spend about $2.5 trillion on health care every year, $2.5 trillion. That's a remarkable amount of money. That is 2,500 billion spent every year on health care. Yet we still have over 40 million people with no health care coverage. Now, if someone gave you a budget of $2.5 trillion, would you come up with the health system that we have today?
Hopefully not.
Yeah, hopefully not. Probably not. So I think what we have to recognize about the US health system is that it was not designed intelligently. It's actually evolved with multiple competing interests and multiple competing priorities. And the entities with the greatest political clout are the ones who get the largest slice of the pie. So if you are, for example, an insurance industry, healthcare insurance industry, are you making a lot of money at healthcare? Absolutely. Hospital organizations, physicians organizations, pharmaceutical companies, biotechnology companies are doing just fine. They're very profitable. But as an American Indian living in poverty, depending on IHS, are you doing okay? Well, absolutely not. So it's not an issue that we don't have enough money in healthcare, we just don't have the right priorities. We prioritize profits over saving lives. And that's just the way our system works. So it wasn't designed intelligently. It's multiple competing interests for a large pot of money. I look at the Indian Health Service user population as kind of an underinsured population. We have some access to basic services, but we don't have the types of services that we need. And as we'll discuss, Indian Health Service is actually not health insurance, so we'll talk a little bit about that. So the graphic here on the left is right from the IHS website. It talks about the legal basis for services to American Indians and Alaska Natives. And you can see it goes all the way back to the US Constitution. We're actually the only population mentioned in the Constitution, and it's actually in the Commerce Clause. Article 1, Section 8 states that Congress shall regulate commerce among the foreign nations and the Indian tribes. So even back in the US Constitution, we were put on par with foreign nations, and that we have sovereignty that's recognized all the way back to the US Constitution. On the right, I know it's in very small print, but it's one example of many hundreds of treaties that were signed between the tribal nations and the federal government. This one happens to be with the Potawatomi Nation in 1846. And at the very bottom, it states the United States will give at the same time promise of all proper care and protection. Promise of all proper care and protection. There's no expiration date on this, just like there's no expiration date on the US Constitution. Have we received all proper care and protection? Well, not even close. So we'll talk a little bit more about that and how that directly has an impact on cancer prevention and cancer treatment. So we do have a government-to-government relationship, and in truth, it's governments-to-government relationships. We have over 560 federally recognized tribes that are all sovereign, have their own elected leadership, and have their own relationship with the federal government. So if we look at the Indian health system, Indian health prior to 1955 was actually part of the Department of Interior. And it was the Transfer Act in 1954 that moved the Indian health program out of the BIA and into, at the time, Department of Health, Education, and Welfare, which is now Health and Human Services. So IHS in its current form was started in 1955. Has the world of medicine evolved since 1955? Well, significantly. And unfortunately, IHS has not kept up with how different the world of medicine is. In 1955, that's before Medicare, before Medicaid, before HIPAA compliance, before medical subspecialization. It was a very different world of medicine. Well, in 1975, the new players were the tribal programs under Public Law 93-638. And of course, the 638 law allows the tribes to take over the management of healthcare programs from Indian Health Service and manage it locally. So in Indian country, the term 638 has actually become a verb, hasn't it? We're going to 638 the hospital, or we're going to 638 our clinic, meaning to take it over. So back in 1975, was the IHS happy and willing to give up control and money to the tribes? Well, absolutely not. There's a lot of documentation that shows how paternalistic their approach was. And there was a lot of contentious relationships at the beginning of this process. It's much improved now, and certainly in some of our areas like Alaska and California, the entire area is under 638 contracts and compacts. So much more tribal control. And actually, as of last year, 55% of the IHS budget is now managed by tribes. Well, even though Medicaid law passed in the 1960s, it wasn't until one of the reauthorizations of the Indian Healthcare Improvement Act that allowed IHS and tribes to bill Medicaid. So now there's a third player, right? The billing system under Medicaid, and because of high rates of poverty, we have a lot of people on Medicaid. So for example, when I was working in Phoenix, if I saw a patient at Gila River, which is a 638 program, and if we diagnosed or suspected cancer, the first thing we would do is get them enrolled in Medicaid if they're eligible. The second thing we'd do is send them to Phoenix Indian Medical Center, which is an IHS facility. So suddenly one patient has engaged 3 separate systems of care at 3 separate levels of government. Is it possible that things could fall through the cracks? There's gaping holes in that relationship, unfortunately. And do we have case managers that overlap all 3 systems? Well, no, we don't. Do we have patient navigators that overlap all 3 systems? No, we don't. We have the most complex health system in the country, and I think that bad policy and bad coordination of services is adding to our health disparities. So let's look at health disparities. If we look nationally, comparing where I work now, the Aberdeen area Indian Health Service, which is North Dakota, South Dakota, Nebraska, and Iowa, we see about a 10-year difference in life expectancy. Now, life expectancy is how long you would expect someone to live who was born this year. So it's a projection. It's based on scientific principles, but in truth, it's our best educated guess. How long will someone live who's born this year? Whereas if you measure the age at death in a given year, that's an actual measurement, not a projection. The average age at death, or median age at death in South Dakota in 2009 was 81 for the general population and 58 for American Indians. Median age at death, 58 for American Indians. That's worse than many third world nations. And we don't have to go overseas to find third world health conditions. It's right here. It's on our reservations in this country.